I'm delighted that we have Professor Srinath Reddy here from who is the president of the Public Health Foundation of India. And we have invited him to give a talk as a guest speaker at the end of our annual scientific meeting, this particular session. He's a man with a huge list of accolades, a long experience. Under his leadership, the Public Health Foundation India has established 5 institutes of public health in different regions of India to advance multidisciplinary public health education, research, health technologies, and implementation support for strengthening health systems. Professor Reddy has been a researcher, teacher, policy enabler, advocate, and activist who's worked to promote particularly cardiovascular health, tobacco control, and appropriate nutrition across the life course. So he's well placed to deliver this short talk in moving research to policy and practice, which is an expanding agenda for chronic diseases. So Professor Reddy, welcome, and over to you. You don't have any slides. I think you're just going to talk to us, which is great. So if people want to turn their cameras on, so Professor Reddy actually is looking at people when he's delivering a talk, then that's actually also to be advocated. Thanks. Over to you, Professor Reddy.
Thanks a lot. I have missed much of this conference, but I've seen the program and I believe it's been very rich in content and also in context, because I was just listening to the last conversation about the need to look at the needs of indigenous people, and I believe the context is very relevant. Clearly, in a conference that is focused on guiding science into policy and its application and action, we really need to look at the whole pathway of translation. We do recognize the need not only to generate knowledge, but also to move it towards application with impact, so that we do clearly see results. But that impact should also result in equity, because you can have impact in a population without having the existing health inequities either reduced or even possibly exacerbated, because the impact could be reflected in benefit only to certain sections of the people. We also recognize, even at the global level, that impactful interventions, whether in public health or in clinical medicine, may actually be much more confined to some of the countries which can have the health systems as well as the resources that can implement those impactful interventions, whereas many other countries may not be able to do that. And therefore, both in terms of equity at the national level as well as equity at the global level, we may see considerable challenges. So the purpose of research, especially in public health, is to generate evidence-informed, context-relevant, resource-optimizing, culturally compatible, and equity-promoting recommendations for policy and practice. I'm consciously saying evidence-informed and not evidence-based, because evidence-based has been frequently confused with randomized controlled trials, whereas evidence can actually come in from multiple streams of knowledge, including tacit knowledge and experiential knowledge. I'm saying resource optimizing rather than resource sensitive, because resources can certainly be increased at any point in time. And culture too is dynamic and is potentially alterable. But evidence and equity are absolutely of prime importance. And therefore, we need to look at how research can address all of these dimensions, but particularly looking at the strength of evidence and also the impact ultimately on equity. So here we recognize that context matters. And between 1990 to 2015, research aimed to get non-communicable diseases into the list of global and national health, because we recognize that whatever was happening, plenty was happening in the realm of research on chronic diseases, was mostly happening in high-income countries or upper middle-income countries, and did not really reach to benefit the populations of low and middle-income countries, which are larger in number and have actually higher burdens of chronic diseases. So between 1990 and 2015, the aim of research was mainly to try and get non-communicable diseases onto the radar screen of global health policy priorities. And that indeed succeeded with the UN Political Declaration of 2011, as well as particularly with the Sustainable Development Goals of 2015. And we have seen that the context, again, has been changing, which actually requires NCDs also to position themselves in the changing global context of primary healthcare-led universal health coverage, which has emerged as an important platform for health system, particularly in the 2018 meeting on primary healthcare. But we also recognize that there is a great deal of emphasis being laid on high-quality health systems and how we can actually not only provide access and affordability, but also ensure greater quality within the health systems. And there again, there are a lot of asymmetries and inequalities that exist between countries and within countries, which need to be addressed. So it is in this context that research must be focused on in order to ensure that we provide the right kind of direction as well as impetus to the generation of knowledge and to the translation of knowledge into equitable impact. Now, we know that when we talk about how research is focused after 2011 and 2015 on the global NCD targets of 25 by 25, which was set in 2011, and 1/3 by 30, a 1/3 reduction in premature mortality between the age of 30 to 70 years, between 2015 and 2030, we have moved from knowledge to action. But has it resulted in impact? And has that impact translated into equity? Those are the issues that we now need to examine very clearly. And also we must recognize that while it was convenient to look at a few diseases and a few risk factors and focus particularly on premature mortality, we do need to pay attention to a larger number of chronic diseases as well as mental health. But we need to pay attention to morbidity, and we also need to ensure that we are not confined necessarily to the narrow age band of 30 to 70, because NCDs do occur below the age of 30, and we need not take an ageist stance that lives above 70 do not matter. So we do need to really expand even the horizon, even though the metrics by which we are measuring impact by the SDG targets are indeed the 30 to 70 mortality. But ultimately, we do need to pay attention to all of these and adopt a life course approach with a strong emphasis on health promotion, disease prevention, early detection, cost-effective care, and ensure that we actually provide an opportunity for every society to reduce the burden of chronic diseases, both through mortality reduction and by reducing morbidity as well. It is not that while we move into implementation research from etiological research, that etiology doesn't matter. We still have a lot to deal with epigenetics and the microbiome. And again, this gives an opportunity for a lot of research within populations and across populations to discover where the potential points of intervention are. But nevertheless, we have adequate amount of knowledge already garnered, and therefore effective translation of that knowledge into impactful interventions is going to be the critical priority at this moment. And therefore, we are really looking at action at multiple levels. We are looking at action at the level of health systems. We are looking at the action at the level of multi-sectoral policies and programs. We are looking at action at the level of community engagement, and participatory research was emphasized in the previous session. So when we are really talking about health systems, I would like to make a strong pitch that while we need to look at all of the health system in a unified manner, it is the primary care settings that take the highest priority. If the question is asked, has COVID changed the priorities now overall, because have NCDs sort of faded into the background and slipped off the radar of policymakers who are now worried only about pandemic control of the current pandemic and prevention of the future pandemics? I believe we have several arguments to make. I believe that given the fact that chronic diseases are the major comorbidities which are driving severe disease, hospitalization, and death in COVID-19, and that's true of other respiratory epidemics as well, whether it is SARS or influenza epidemics, the fact that this whole syndemic has to be considered is a very clear recommendation that we have to make, so that the focus is on not only preventing the pandemic or even responding to it through appropriate infectious disease surveillance, but ensuring that the persons at risk are greatly reduced in numbers in any population by having an effective prevention, early detection, and control of non-communicable diseases, which form the largest basket of comorbidities. Even, for example, when we are trying to prioritize people who require vaccination, when vaccines arrive afresh, then when we are looking at people who have NCDs as comorbidities, we find that many health systems are not even able to identify who are the people with NCDs as comorbidities, because most health systems have not detected people who have had diabetes or hypertension. Very large numbers of them have even been undetected in low and middle income countries. So how do we actually ensure our health systems, not only from the point of view of improving NCD control, but contributing to better management of infectious disease outbreaks and pandemics? So those are some of the arguments that we need to make. So when we come to primary healthcare settings, we do need to talk about health workforce and how are we going to actually ensure that we build up sufficient capacities in our health workforce in order to provide the appropriate care. Particularly, can we have a technology-enabled frontline health workforce which can deliver many of the primary healthcare services for chronic disease prevention, detection, and control? So that is going to be an important element of research as well. What is the level of skill up that's required? What is the level of scale up that is required? All of these will become extremely important. And when we look at the quality of healthcare, there are 4 dimensions that we really need to assess. Are the interventions beneficial? Are they safe? Are they resource optimizing, both in terms of financial resources and human resources? Are they appropriately utilized? And are they providing satisfaction to the patient, the family, as well as the care providers? These are, again, elements which are eminently researchable and do need to be researched in the context of the health systems. So in the whole area of health system research, there are other elements. What is the nature of community engagement? What is the level of participatory research, where the community is not being merely treated as a willing instrument of the researcher's intent, but as an enabled and respected and recognized partner in the research enterprise? So as we move along on this, we come to technologies as well. And there we do need to recognize that there is a great opportunity for looking at new technologies, be it telehealth or mHealth, or whether it's artificial intelligence that's being developed. All of these are going to be researchable, but again, in the context of health system application. And how do we use the big data? How do we ensure that data are appropriately customized for each level of care and each nature of prevention to diagnostics to treatment? How do we ensure that our hospitals are strengthened in terms of better data utilization as well as data secrecy? But more important, how do we ensure that technologies can assist self-care and assisted primary care. And how do we assist technologies through health technology assessment, and what is the nature of regulation that's going on, and how effective is that regulation? So when we are really looking at quality of healthcare, as I said, there are 4 dimensions that I'd like to look at, and those are things that we ought to fit into our research agenda, even as we build in new innovations. I believe that we need, as we do all of this, to renew, refresh action through iterative cycles of application and appraisal. And therefore, we continue to move towards better performance of the healthcare system. But we do require multidisciplinary research. It is absolutely critical, whether we are moving from policy to practice or from monitoring to evaluation. We do need multidisciplinary research partnerships. We need to build in complexity science. We have far too long depended upon linear models, and our research is reflective of that. But if COVID-19 has taught us anything, and many other experiences also have taught us anything, that linear models do not usually work, except in certain specific circumstances. Even randomized control trials are brilliant for assessing vaccines and drugs, but not necessarily population interventions in a very dynamic, changing context. And therefore, we require to build in complexity science, Bayesian models and analytics, mixed methods of research with both quantitative and qualitative methods, and recognize that enlightened policy, because ultimately, if you want to translate research into policy, enlightened policy needs scientific credibility, financial feasibility, operational steerability, and political viability. Scientific credibility through biomedical, epidemiological, and clinical research. Financial feasibility, is it cost effective? Is there extended cost effectiveness, not only of best health for the money, but also the best financial protection for the money, so that you're preventing impoverishment? Is it affordable, even if it is cost effective? So you require health economics research. Operational steerability, is it scalable? Is it sustainable? You need implementation research or health systems research. Political viability, is there a ready and receptive constituency among the policymakers, among the public? Who is opposing? Who is supporting? Who are the potential allies? Who are the potential opponents? And there are a number of vested interests that we are aware of. So we require social science research. And therefore, even when we look at resources within the country, global resources being allocated, are they being appropriately allocated? Are they being equitably allocated? So even research resources, for example, are they really going to the low and middle income countries in the manner that they should? All of these are potentially researchable and can galvanize research further on in order to deliver impact. So there is an action almanac that we need to consider. That action almanac is to assemble allies, adopt an agreed agenda, amplify advocacy, accelerate action, and assert accountability. And while this is an action agenda, each element of that, again, is eminently researchable. How are we actually building good multidisciplinary teams for research and subsequently also for implementation and advocacy? How are we ensuring that the agenda that we are developing is context relevant? How are we actually ensuring that we are building up different coalitions of multiple actors, including civil society and community groups, for effective advocacy? What are the dynamics thereof? What are the enablers? What are the barriers? And as we are accelerating action and asserting accountability, what is the impact? And how are we, is it equitably distributed? All of these are eminently researchable. So I believe as we have moved now from prioritizing etiological research while not abandoning it, but prioritizing, prioritizing implementation research over etiological research, we have a considerable amount of scientific enterprise that must accompany that. And therefore, as we are trying to translate research into policy and practice, we must maintain that momentum by addressing each of these links and ensure that what we produce in terms of knowledge is impactfully translated into results. But at the same time, that policy and practice are invigorated constantly by revisitation of both the nature of interventions as well as their impact through fresh research. Thank you.
Professor Reddy, thank you so much for that very stimulating talk. It was almost like a huge wish list of what we should be doing with implementation research going forward. And I think that each and every one of us within the participant audience today should find some takeaway message. I wondered if there was any questions from the floor. Just please pop them in the chat or raise your hand, and if my team can scout the hands if they're raised. But perhaps one of the things I'd like to ask is, do you have any tips for undertaking multidisciplinary science, Professor Reddy? Because it's often that our institutions are quite siloed in the teaching of disciplines. There is a bit of a challenge in reporting multidisciplinary science, you know, who is the first author? It's that sort of recognition. How do we sort of work to promote team science when multidisciplinary research is what's required? Any tips?
Well, it's a major challenge because it requires a culture shift among funding agencies, where committees that allocate grants are generally dominated by subject experts from a particular discipline and may not have an appreciation of the need for multidisciplinary research. Promotions are judged on the basis of your position in the list of authors, first or last or second author. So there are multiple barriers, I agree. So that is where I believe we need to change that, because there are universities also now looking at the overall impact in terms of what impact it has had on policy or actually clinical practice. And we must give much greater weightage to that. And there, the whole team may be seen as a contributor rather than just the first author or the last author. But that is something that we must really look at. But one of the ways in which we must also push for this is change the way the funding of research is done. It may not be possible at the level of the PhD, but certainly postdoctoral fellows from different disciplines can be brought together with a directed research grant, which specifically asks for multidisciplinary teams to be set up. And if we can actually instill the culture of collaboration at that point in time, that will be ideal from our point of view. And that is where we must also try and bring that mindset even during our training, whether it's in public health or in clinical medicine, in the whole area of research training. We need to produce T-shaped individuals, those who have depth and continue to acquire depth in certain areas of research, but they are fairly receptive, sensitive, and welcoming of other disciplines and have an understanding of their role so that they can easily collaborate when required to solve a complex problem. So I think even in our training methods, we must change that. And perhaps one of the best ways to deal with that is to start with clustering of postdocs from multiple disciplines, have specific directed grants, and perhaps Wellcome could do that and actually put some money behind it so that that actually breaks the silos. Because we know that complex problems can only be solved through multidisciplinary research.
Thank you, Professor Reddy. Brian, I see that you have, maybe there's a good segue there because that sounded about research capacity strengthening. I don't know if your question related to that, but please go ahead.
Maybe indirectly. Thank you, Professor Reddy. That was a fantastic tour de force presentation in 20 minutes. That was fantastic. My question is, and you kind of alluded to this, I think, in your response to Morven's question about the barriers to doing impactful research. And I think the barriers for younger people doing impactful research are even greater because you know, the research takes so long, the outcomes are indeterminate, the rewards are often not great in terms of high impact factor publications and so on. So what are your thoughts about how younger researchers and academics can learn about undertaking more impactful research? How can we create more reward systems for younger researchers to choose that as their career path rather than other more rewarding career paths for research potentially?
Well, I think we ought to challenge them by asking them to solve problems. It's important that we do etiological research and other research to identify the nature of the problems. Problem diagnostic is important, but even in clinical medicine, you don't stop with diagnosis. You go with effective management. So I think challenging people, even in research, to actually solve a problem is going to enthuse them to try and seek allies across other disciplines. Engineering, for example, if you're really looking at systems engineering, they collaborate across different sections and different disciplines in order to solve a particular problem. So I think that is where we must try and get people to identify the problem and attack it from multiple directions with multiple disciplines. And if we can actually give them the satisfaction of solving the problem, incentivizing it, both through academic recognition and maybe even cash award, I think that's going to be an important element. But the biggest satisfaction will come from actually having solved the problem.
Great, thank you. Any other questions on the floor? I don't see anything popping into the chat. A lot of thank yous and great presentations. Catherine, hi. Professor Law, Catherine Law, hi, yes.
Hello, nice to see everyone. I'm connected to the GACD because for a long time I chaired the joint peer review panel. So I also have a wish list probably longer than Professor Reddy's excellent wish list, but thank you very much for a great talk. I was going to put a comment in the chat actually, but I would just be glad on Professor Reddy's reflections. I've been thinking that if the question of the research comes from the real world, from affected communities or from policymakers or local leaders, then it's unlikely to be a monodisciplinary question because people are out there don't think like that. And I suppose that I was just reflecting on the communities practice session I went to earlier and wondering whether requirements, as GAC almost does, for engagement of stakeholders of all sorts is a helpful way to promote multidisciplinary research, because the sorts of questions, say, politicians ask aren't just economic ones, even though they're always interested in price, and they aren't just effectiveness ones. I wonder what you thought about that, Professor Reddy.
Yeah, certainly. I think if we can have what we may say demand responsive research, both from the communities who are going to be the principal beneficiaries and from the politicians who are going to be the beneficiaries of people's satisfaction if things work well, I think then we can actually stream our research. It doesn't mean that every time our research has to be demand driven, but at least it has to be demand responsive substantially to identify the real problems and try and find solutions. And we, in that process, may try and discover new questions which may not have been asked, but answering them will help answer the bigger question that has been asked. So that is fine. So we may still come across some etiological research, some other elements of intervention research, but I believe the important thing is to try and make it as useful to both the communities as well as the politicians who are allocating the resources to draw satisfaction from. And there we will be driven to multidisciplinary research.
Thank you for those thoughts. Any further questions? I don't see any further hands up, and I've got a watchful eye on the clock, and I think we are now approaching the end of this particular session.